Hello and welcome to Health Affairs This Week. I'm your host, Jeff Byers. We're recording on July 23rd, 2025. Just as a reminder, Health Affairs Insider Program released a new report on the healthcare workforce. Check that out. Today, I'm going to turn over the program to Health Affairs' very own Chris Fleming to chat with Georgetown University's Katie Keith. Chris and Katie, welcome to the program.
Thank you, Jeff. Thank you. And Katie, thank you for joining us.
Yeah, thank you. It's always a miracle that I get invited back. So I'm happy to be here. And, Chris, together with our powers combined, did the Following the ACA column for 5 years. So it was not insignificant that we were covering all the ins and outs then and back at it, including with big, budget reconciliation legislation like what we're going to talk about today.
Indeed. And what Katie is referring to, as many of our listeners will know, is the so-called One Big Beautiful Bill Act, which went through both the House and the Senate with record speed and then was signed by President Trump with much fanfare on July 4th, on Independence Day. We'd like to start by talking about some of the contents of that. And it was certainly a big bill, and the contents are many. And before we start on the program, I do want to mention to listeners that Katie wrote extensively on this, as did others for Forefront in the Health Policy at a Crossroads series. So we'll only have time to touch on a little bit of what's there in written form today. So definitely encourage you to go check that out. So I figured, Katie, we'd start talking about the One Big Beautiful Bill and what's in it by focusing on the Medicaid pieces of the bill. So can you tell us what we should know in terms of the Medicaid changes that are in the bill?
Yeah, absolutely. And even before I jump right to Medicaid, I think, Chris, you said this, it is a very big bill. It was 870 pages long. It was a very fast bill. So I was looking back at my notes. This was formally introduced on May 20th, and it was signed into law by President Trump on the 4th of July. And so you don't often see bills this big and this significant move that quickly. And, we'll run through some of the details, but suffice to say, this bill, enacts the largest ever cuts to the nation's safety net programs. So about $1 trillion in cuts to Medicaid, more than $280 billion in cuts to SNAP. I think we're about to see, some really significant impacts as this legislation starts to go into effect, which I know is what we'll talk about here. And then earlier this week, we got final numbers from the Congressional Budget Office, which we did not have when the bill was signed into law. And CBO, is out with its analysis of, 10 million more people will be uninsured as a result of the bill. You add that to another 5 million more uninsured folks from the impact of a Trump administration marketplace rule, which we'll also talk about. And if Congress fails to extend the enhanced premium tax credits for the Affordable Care Act. So looking at, potentially 15 million uninsured over the next 10 years with this legislation, plus some of the other policy changes that I talked about. So that's the highlights, I think, as we go into this conversation in some additional context. But on Medicaid, I already said this, but, it's some of the largest cuts. I think it is the largest cuts to the program in history. Maybe I'll start with the work requirements. Some people prefer to call these the work reporting requirements because we know Medicaid beneficiaries overwhelmingly work or are caregivers or are in school or have, the vast majority have a reason that they, should be exempt from or are already in compliance with work requirements. But the reporting, as we know from experience at the state level, can be very burdensome. And so, now in all 50 states, beginning essentially with 2027, states will have to roll out these new mandatory work reporting requirements. There's a ton of questions about implementation and how this will be set up. I think recognizing that this will be hard for states to do in, just a little bit over a year to try to get these systems into place. In the Senate version, Republicans in the Senate added a sort of extension or a waiver where states can apply to push that deadline out essentially to 2029. That will be fully up to the discretion of the folks in the Trump administration. So we'll see, how many states make those requests and how many are granted. But in the meantime, I think states are, setting about trying to figure out what they do next. For listeners who are into the wonkier legal stuff, it certainly jumped out to me as I was reading the final text that a lot of the implementation of the work requirements is exempt from the Administrative Procedure Act. And so, Normally that is an issue that causes a lot of litigation and things that I write that Chris helpfully edits. So we'll sort of see how that plays out, but that jumped out to me. So that's on the work requirements piece. We're expecting, if you look at the Congressional Budget Office and others, expecting to see significant losses there and really will disproportionately affect Medicaid expansion enrollees. So I think this is one of the examples of how the bill sort of undermines the Medicaid expansion under the Affordable Care Act. I would give you, 3 quick more categories of stuff under on the Medicaid side under the new legislation. There's a lot, in addition to work requirements, there's a lot of other paperwork and administrative burdens that states and beneficiaries are going to have to grapple with. One example is, more frequent eligibility redeterminations for Medicaid expansion enrollees, where, you had to prove your eligibility once a year, and now you'll have to do it every 6 months. New copays for certain Medicaid expansion enrollees, so folks who are right above the federal poverty level could face copays of up to $35, kind of up to 5% of your income could be going towards cost sharing, which has not been allowed before. New limits on retroactive coverage, which I think will probably, hurt hospitals and result in more uncompensated care. The second category would be, which has gotten a lot of focus, I think, given the impact it's going to have on states and hospitals, is making changes like freezing provider taxes, addressing the hold harmless provisions in those provider taxes, limiting state-directed payments, all these, trying to tamp down on all the ways that states have many states, almost all of them have, used these mechanisms in some form or fashion to finance their Medicaid program, which is going to shift, I think, cost to states as they look for other ways to make up this revenue. So a lot of those changes, some kick in 27, some will kick in 2028 in earnest. There's been a ton of discussion there, especially because of how this is going to impact hospitals. And then the third category of Medicaid changes that I will flag is which we've already seen start to play out in real time. So unlike the other changes that I just talked about, which phase in, the bill included a provision to prohibit federal Medicaid funds from flowing to Planned Parenthood. And it has, the bill has a specific definition for prohibited entities, but essentially healthcare providers that perform abortions and receive a certain amount of Medicaid money in 2023, and it would prohibit those federal funds for a year. This limit is one that went into effect right away, and Planned Parenthood, Federation of America, which is a national entity, and then several of its affiliates have already sued. We've seen temporary restraining orders and partial preliminary injunctions, and even earlier today, the Trump administration filed a notice of appeal. So that's one, I don't know how that is going to play out, but that part of the legislation is actively being litigated right now, and we'll see sort of what Planned Parenthood's fate is. That could be a devastating change for access to a whole bunch of care, certainly abortion, especially in states where it's lawful, but, contraception, cancer screenings, a whole range of services that Planned Parenthoods provide to Medicaid beneficiaries right now.
Well, thanks, Katie. And, as if all of that weren't enough, that's only one of the categories of changes in this bill are now law. There are a whole bunch of changes to the Affordable Care Act. Could you talk a little bit about those?
Yeah, absolutely. And sort of similar to, I guess dissimilar to the Medicaid changes, a lot of these start right away. Many of them start beginning in 2026. And so are changes that are going to have to be adjusted for this coming open enrollment period, which starts in November. So some examples here, the legislation would prohibit marketplace premium tax credits for, those who are low income and use special enrollment periods, would make some changes around health savings account eligibility, would beginning in 2026, eliminate subsidy eligibility for individuals who would be eligible for Medicaid except for their immigration status, which I think in some states is a significant number of people that could, we'll see how that affects the risk pool. And then in 2027, we'll see additional immigration eligibility restrictions kick in. So for since the marketplace is opened, many different types of lawfully present immigrants have been eligible for tax credits. I'm thinking of refugees, asylees, various categories of folks who are in the country lawfully have been able to access coverage through the Affordable Care Act. And all that is going away beginning in 2027. The category of law, you can't see me using air quotes, but lawfully present will be quite limited under the new legislation. So I think that will be very disruptive for many people. We'll start to see the elimination of financial protections for folks who get premium tax credits, but maybe misestimated their income for, very reasonable reasons, but might have to repay some of that. So folks could get a real, surprise when they file their taxes beginning in 2027. And then I think the big change that a lot of insurance companies and marketplaces are already probably stressed about is a provision of the bill that would functionally ban automatic re-enrollment for those who receive premium tax credits. And, for those who have employer-based coverage or Medicare, any other type of coverage, you kind of enroll once and then you stay enrolled until you take action. And you always have the option to go in and change your coverage. And that's been in place with the marketplace since it opened. But this would really require significant changes. So each year, folks would have to come back to the marketplace, verify their eligibility again. And I think it's going to could be incredibly burdensome for marketplaces and consumers, depending on how the Trump administration implements it.
And then, of course, another area which I think people, even proponents of the bill or people who voted for it, recognize where the changes might be burdensome is rural health and rural hospitals, which have already been under strain. There were some attempts to deal with that in the bill, but there's some real questions as to how that will play out. Can you talk a little bit about that?
Yeah, absolutely. So I think I would assume recognizing what some of the impact of this legislation is going to be on rural hospitals. I think you're exactly right, Chris. The legislation includes a 5-year, $50 billion, they're calling it a rural health transformation program. This would begin in 2026, run through 2030. It's about $10 billion a year. There's an entire state application process. I think Forefront has published some terrific features from Ann Reed and Sarah Rosenbaum and also Carol Johnson that dive into the details in a way that I will spare all of you. But this is going to move very quickly because applications and approvals are due by December 31st of this year because this program starts quite soon. I think Anne and Sarah call the program exceptionally modest, were those words relative to the cuts that, this bill is going to cause to Medicaid. And I think one of their chief criticisms, and hopefully I will do them justice, is the way that this program is set up. It doesn't require states that put in for it, doesn't require them to directly fund rural hospitals. There's a whole long list that you can see in their piece of all the different ways states could use this money. And it's important stuff, but it could be workforce and, recruitment and substance use disorder treatment and value-based care. And I think the concern is hospitals might go under because of this change. And so, maybe you could encourage states to put in for ways to directly fund rural hospitals, but it does not appear that that is what this program will necessarily do. So I think a lot of questions, and I'm sure the folks at the Centers for Medicare and Medicaid Services are trying to quickly put together what that application process is going to look like. And again, if you have to get those requirements out and then get states to apply and then, approve or deny before the end of the year, I just think all of this, while all these other changes are also happening, by the way, I think it's going to be a lot for states, a lot for even the feds to do here too.
I know, unfortunately, our time is limited, but I'd like to touch on, there's a whole bunch of other stuff, obviously, that we won't be able to get to, but I'd like to briefly talk a little bit about what is in store for Medicare under the bill, and then maybe what other, if you could highlight some of the other parts that we haven't gotten to that listeners should be aware of.
On Medicare, I think there was a policy choice from the White House on down not to make, too many changes to the Medicare program. So you did see a lot lighter touch there, let's say. One of the things that was in the bill was a 1-year fix to the Medicare physician fee schedule. I think that is important. I will also say the House bill would have fixed it permanently, and that did not carry through to the Senate, but at least there's kind of 1-year relief there for Medicare physicians. And then Congress extended the exemption for orphan drugs under the Medicare drug negotiation program. And I know there have been some great Forefront authors who have written about this and what the impact will be. So not a huge change there, but not insignificant either. So the changes, again, to Medicare are relatively small, but still I think would be notable on their own in any other context. It just happens to be that this is a mega piece of legislation.
And then what are some of the other sort of the pieces that fall outside the categories we've talked about, but you think should be highlighted?
Yeah, there's more to say. I think one I might put on the table for listeners in case there's interest is there were some changes to health savings account eligibility. That's been a major priority for, say, employers or pharmacy benefit, that kind of thing, folks who work on those issues. But the bill would allow, or the legislation allows, health savings account reimbursement for direct primary care services arrangements, which is something, again, folks have been lobbying for years to get a kind of a carve out or get some clarity there. And then another clarification that high deductible health plans can offer telehealth on a pre-deductible basis without losing their status that way. So again, the House version of this bill had many, many, many more changes on health savings accounts and would have, for example, codified the Trump administration's rule on health reimbursement arrangements, that kind of thing. You really saw modest changes by the time it made it through. And I think some folks were quite pleased to see these HSA changes that I just mentioned.
And then very briefly and finally, you mentioned a couple places, the physician fee schedule, full fix, some of the HSA stuff just now. You mentioned a couple places where there were elements in the earlier versions of the legislation that didn't get into the final law. What other pieces did not get into the final enacted version that might come up again as we move forward?
Yeah, it's a great question. And there were a dizzying array of policies being floated throughout this process that we wrote about. So I think other things that would be on my list, certainly, there was a proposed limit on treatment for gender dysphoria for transgender people through Medicaid. I will say there is now, earlier this week, what looks like a new proposed rule that would do this through the administrative process. So maybe that comes back in the legislation. I think that was kicked out under the Byrd rule. And so, they might be looking for other ways to do that in the future. We could see other attempts on abortion access. Some of those, other than the Planned Parenthood provision, there were other, the cost sharing reduction funding that might come back. I think there's still some Republicans in the House who seem very committed to making changes to the FMAP, the federal matching amount to Medicaid expansion. That continues to be talked about. So, there were lots of things left on the cutting room floor that, I just get the sense aren't necessarily gone forever. So it'll be important to kind of stay vigilant about what's going on in Congress.
Well, thank you very much, Katie. That was a heroic tour, and you almost as quickly as the bill moved through and was enacted, I think you moved us through many, many pages of legislation, also in record time. So thank you very much, and I'll throw it back to Jeff.
Chris Fleming, Katie Keith, thanks again for joining us today on Health Affairs This Week. If you, the listener, enjoyed this episode, please send it to the Odysseus in your life. Thanks, and we will see you next week.